Good morning, everyone. This is Mark Erkin, and I want to welcome you to our Friday morning program. I am really excited for this morning's program. But before I get started, I do want to call your attention to what's on the screen, which is the launch of Thyro, which refers to Thyroid International Recommendations Online. This is an initiative that we have been working on for the better part of a year and a half. I would encourage you to either visit the site using the tyro.expert, or you can just click on the URL that's there, and that will get you there. You'll hear more about Thyro in the coming weeks as we promote this initiative. But our mission for Thyro, which you will be hearing much more about, is to broaden our Friday mornings platform to include a wide range of topics. And one of those initiatives is to include a series of lectures that we refer to as primers, and which are intended to provide more detailed information about a particular area of thyroid nodule and thyroid cancer management. And this morning's lecture is a primer on the use of radioactive iodine in thyroidology. And I am thrilled to have Dr. Monica Rossleigh join us this morning from Australia. Dr. Rossleigh is widely considered a world expert in nuclear medicine, and I've had the extreme pleasure of working with her on the executive committee of Thyro, where she has played an active role in the development and in steering us to the launch of that program. Dr. Rossleigh, as I mentioned, is in Australia, and she traveled to New York during the course of her training to receive fellowship training in nuclear medicine at Memorial Sloan Kettering. Currently, she is the chair of the nuclear medicine department at the Prince of Wales and Sydney Children's Hospitals, and she is also the chair of the multidisciplinary thyroid cancer program, Prince of Wales Hospital. It's my pleasure to introduce Dr. Rossleigh this morning. It's morning in New York, but it's a late evening in Sydney. And as always, I want to encourage you to enter your questions, and I'll do my very best to direct those to Dr. Rossleigh before the end of the hour. So thank you very much for joining us. And Dr. Rossleigh, thank you again for putting this whole program together. Much appreciated.
Oh, it's a pleasure. So this is where I'm from Sydney. So this photo was taken on Australia Day, which is in January, and these ferries in the front here, they transport people across the harbour on Australia Day. They have a ferry race. So that's just a picture of that now, Harbour Bridge and Opera House. But the reason I'm here today is to talk about radioactive iodine use in differentiated thyroid cancer. And first of all, I have no financial disclosure to report. I'm here in Sydney. Dr. Patterson, who's also involved in this organisation, is up here in Brisbane, which is about 600 miles north of Sydney. Okay, so radioactive iodine, it has a half-life of 8.1 days. And it emits both beta rays, which are short rays which deposit energy locally and enable the destruction of cells by radiation, but it also emits gamma rays to enable imaging to show the distribution of the disease treated. So the first treatment to deliver targeted radiotherapy internally is radioactive iodine. It was initially administered in 1941 at Massachusetts General Hospital in Boston by Dr. Hertz for hyperthyroidism originally, and later for thyroid cancer. So it was really the beginning of theranostics. We now have other modalities in theranostics. For example, we do iodine 123 MIBG imaging in children with neuroblastoma, and I-131 MIBG can be used to treat the metastatic foci demonstrated on the scan. And we also have gallium dotatate imaging in neuroendocrine tumours, and we can then label with lutetium-177, which is a beta emitter, and treat those tumor deposits. And even more recently is gallium-68 PSMA imaging. And then with the same PSMA, we just change the radiotracer to lutate. And it's also the beta emitter, and it treats the metastatic prostatic carcinoma foci. So radioactive iodine, the first point I want to make, it can only be administered to thyroid cancer patients who have undergone total thyroidectomy. So if you have a patient who's been treated with a lobectomy, you can't expect radioactive iodine to get rid of the remaining thyroid lobe. And if it's deemed on the basis of parameters, histology and whatever, that radioactive iodine is required, then the patient must proceed to total thyroidectomy before radioactive iodine can be used, because it is only efficacious in treating small volume disease. And as a general principle, all large volume disease needs to be resected first, where possible, prior to the administration of radioactive iodine. Now, what are pre-treatment considerations? You should perform full blood count and renal function, because in the presence of impaired renal function, radioactive iodine excretion is delayed, with a resultant potential adverse effect on the bone marrow. Pregnancy certainly requires exclusion prior to the administration of radioactive iodine, and patients are asked to avoid pregnancy for at least 6 months after the radioactive iodine treatment. And breastfeeding also needs to be ceased about 3 months prior to the administration of radioactive iodine. A diagnostic radioactive iodine 123 scan to exclude breast uptake is advised prior to radioactive iodine treatment. I can tell you we do this routinely in women who've developed thyroid cancer during pregnancy, breastfeeding, and when we are going to give them their radioactive iodine once they're finished breastfeeding, we always do the scan. I had one patient who 3 months after cessation of breastfeeding, she still had breast uptake. She was very angry with me when I wouldn't give it to her, and we delayed the treatment for a month. And at that time there was no breast uptake. And 2 years later, she developed breast cancer. And I'm sure that if I would have given her the radioactive iodine, she would have blamed me for her breast cancer, which was not the cause. Now, if the surgeon needs to do a CT scan with iodine contrast to plan his surgery, that's fine, but we need to wait at least 6 weeks after iodine contrast administration to allow the cold iodine, the contrast iodine, to clear from the body so that the radioactive iodine can work. Now, I have been asked to address the issue of amiodarone. But this is a big problem. Amiodarone contains iodine, which is it ends up being stored in adipose tissue, and it may take around 10 months or longer after cessation of the drug before any kind of uptake is achieved. And so in these patients, you would certainly have to do a pre-treatment scan to see whether there's any radioactive iodine uptake or whether there's still contamination from the amiodarone. Now, all patients need to go onto a low iodine diet for 1 to 2 weeks prior to the therapy, because we want to get rid of the cold iodine in their body to enable the radioactive iodine to have to be able to work. Now, I used to tell patients just don't eat seafood, don't use iodized salt. In our country, they put iodine into bread because we're a bit iodine deficient, so avoid bread and red food dye color. So that's like red lollies, red snakes, and the Coca-Cola, the brown in Coca-Cola's iodine. But now with the advent of the internet, patients say to me, oh, you didn't tell me to avoid this, you didn't tell me to avoid that. So our state health authority has put together a low iodine diet for us to give to our patients. It's pretty tough, and so I usually tell them 2 weeks before, take the easier diet that I prescribe, but for the week prior to the treatment, try and be strict and according to the low iodine diet prescribed by Department of Health. Now, urinary iodine measurement is not routinely recommended. It may be used in a research setting, but it's not routine clinically. But you certainly need TSH elevation to enable the radioactive iodine to be incorporated into the cells. This can be achieved in 2 ways, either by stopping thyroxine for at least 3 to 4 weeks. If you're going to use short-acting thyroxine, tertroxin, then you need to have them on thyroxine for at least 4 to 6 weeks. Put them on the short-acting levothyroxine T3, but they have to be off T3 for 2 weeks prior to radioactive iodine administration, and you must measure the TSH prior to the treatment, and it must be greater than 30 before you give the treatment dose. Now, in more recent years, we've had the availability of recombinant TSH, and that has really revolutionized radioactive iodine treatment. You don't have to make the patients hypothyroid. They tolerate the treatment better, and it is a fantastic alternative to withdrawal, and it can be used in ATA low or intermediate risk disease. In ATA high risk disease, in general, thyroid hormone withdrawal is preferred. If recombinant TSH is used in metastatic disease, the dose to metastatic foci may be lower than after thyroid hormone withdrawal, and so an equivalent or higher administered activity of radioactive iodine should be given. Steroid administration in patients with brain, spinal canal, or superior vena cava deposits should be considered to reduce the risk of acute swelling, which may result in compression of these vital organs. When the radiation works on them, you can get swelling. So what are the factors to consider after total thyroidectomy in deciding on whether a patient should receive radioactive iodine? Well, I always talk to the surgeon and find out what his surgical findings were. Was it a difficult operation? Was the tumor invading the adjacent muscles, the trachea, etc.? And then we closely assess the histological findings. And in general, these are the 2 main factors that we consider before, and including age as well, in determining whether they need radioactive iodine. Now, more recently, molecular marker status has become available, and its role is really evolving. Some guidelines incorporate BRAF and TERT mutations into risk stratification of papillary thyroid cancer, with the combination considered as indicators of high-risk recurrence and appropriate for radioactive iodine therapy. However, this is not widely accepted due to insufficient evidence to support genotyping at the present time, but it may have a greater role in the future. So overall, we have to undertake risk assessment of the disease. That is it low, intermediate, or high, using the American Thyroid Association criteria. Now, pre-treatment investigations. You can perform radioactive iodine scanning before the treatment if the findings alter management. Now, I know the surgeons in my institution, and I know that there won't be much tissue left in the neck, and I'm happy to just proceed to giving treatment if required without doing preoperative scanning. But if a patient is referred from an outside surgeon and I don't have an experience of that, then I may perform pre-treatment scanning. I-123 is certainly preferred because it does not result in stunning, but it is significantly more expensive and availability is problematic. We can only get it once a week on a Tuesday, has to be imported from overseas in our country. If radioactive iodine imaging is to be undertaken, a low administered activity in the order of 2 to 3 millicuries should be given, and no closer than 3 days, no further distant than 3 days prior to therapy is advised to reduce the risk of stunning, which may reduce the efficacy of the treatment. Postoperative thyroglobulin is also considered. It reaches a nadir at 3 to 4 weeks, and measurement at 6 to 12 weeks may aid in decision making. An undetectable thyroglobulin may be considered favorable, and an elevated thyroglobulin may support proceeding to radioactive iodine treatment. Now, in low-risk disease, either give no radioactive iodine, which is my preferred option. I think if it's low risk, then why expose the patient to unnecessary radiation? But some workers advocate low dose remnant ablation with 30 millicuries to facilitate disease follow-up, particularly in the presence of antithyroglobulin antibodies. So you must remember that a 30 millicurie dose is only going to destroy normal thyroid tissue. It's not a cancer treating dose, it's to get rid of normal thyroid tissue. And in my practice, I only give it if there are significantly elevated antithyroglobulin antibodies and I can't monitor the patient with thyroglobulin. So if you destroy the thyroid tissue with remnant ablation, then you remove the antigenic stimulus for the antibodies, they will clear, and then you'll be able to monitor them with thyroglobulin. Remnant ablation has not been shown to reduce rates of recurrence or death. And so in my practice, I'll only use it in the presence in low-risk disease if they've got elevated antibodies. Now, intermediate or high-risk disease, this is adjuvant treatment. In this, we're trying to treat the cancer, not just get rid of normal thyroid tissue. Now, in the guidelines, they recommend anywhere between 30 and 150 millicuries. And 30 millicuries is reserved for intermediate risk disease with lower risk features. But in general, in intermediate risk disease, if you're going to give adjuvant treatment, a higher administered activity should be given, anywhere from 70, 80 millicuries up. Now, treatment of known metastatic disease or ATA high-risk patients, administered activities between 100 and 200 millicuries may be given. Empirically administered radioactive iodine above 150 millicuries may exceed the maximum tolerable tissue dose and should be avoided in patients over 70. Whole body and blood clearance in dosimetry can be used, but this is only available at certain high volume specialist centres. And I think there's only 1 or 2 places in Australia doing it, at Dr. Patterson's unit in Brisbane and down in Melbourne. And unfortunately, we don't have that available. In the States, I know Sloan Kettering does it when I work there. Okay, empiric therapy for patients with negative radioactive iodine scans but elevated thyroglobulin. Patients with no imaging evidence of disease but biochemical persistence or recurrence may be given an empiric dose of radioactive iodine in the range of 100 to 200 millicuries or a dosimetrically determined dose. And in our institution, when we give this empiric therapy, we will do a pre-treatment TSH stimulated FDG PET scan on the morning of the treatment, as this may provide additional useful information. In about half the patients, the disease may be localized on the post-treatment scan or a decline in thyroglobulin occurs. If the post-treatment scan is negative, and/or the thyroglobulin does not fall, then the patient has radioactive iodine refractory disease and further radioactive iodine should not be given. So empiric therapy may be considered if the thyroglobulin is above 10 with thyroxine withdrawal or above 5 with recombinant TSH stimulation, or if there are increasing thyroglobulin or antithyroglobulin antibody levels. You can use antithyroglobulin antibody levels as surrogate markers for tumour. Now, post-therapy scans should always be performed after radioactive iodine therapy to aid in disease staging and to document the radioactive iodine avidity of any structural lesions. And the addition of SPECT-CT imaging to enable anatomical localization of the foci seen on the whole body scan is recommended, and we do this routinely. Now, what are the role of imaging techniques in follow-up? Neck ultrasound examination has become the mainstay of imaging in routine follow-up of differentiated thyroid cancer. And whereas in the past we used to do radioactive iodine scanning in surveillance, it is no longer recommended for low or intermediate risk patients with no biochemical or structural evidence of persistent disease. It may be useful in high-risk patients with biochemical or structural evidence of disease or indeterminate findings. Now, CT or MRI of the neck and chest should be considered in patients with elevated thyroglobulin looking for residual or persistent disease. If these are negative, further imaging is warranted. Fluorinating FDG PET should be considered in high-risk patients with elevated thyroglobulin. In the initial staging of patients with poorly differentiated disease, it can be used as a prognostic tool. If patients are FDG avid, iodine non-avid, that's a poor prognosis, or in the assessment of treatment response to systemic or local therapy. Imaging of other organs with CT or MRI of the brain, skeleton, or abdomen may be performed in patients with elevated thyroglobulin, negative neck and chest imaging who have symptoms referable to these organs. What is the definition of radioactive iodine refractory disease? Patients with known metastatic disease identified may be classified as radioactive iodine refractory in the following settings: in the presence of appropriate TSH suppression and in the absence of stable iodine contamination following a low iodine diet. So if there's absent radioactive iodine uptake in known malignant or metastatic disease, if tumour no longer concentrates radioactive iodine after previously being radioactive iodine avid, if there's radioactive iodine uptake in some lesions but not in others, for example, others demonstrated on PET, and if there's disease progression despite radioactive iodine uptake. What are the possible complications of radioactive iodine? Now, salivary gland damage is the most common complication that I see with this treatment. It can result in xerostomia, extremely dry mouth, and this results in a higher risk of gum disease and dental caries. And the problem is, you've cured the patient of their thyroid cancer and then they have this lifelong problem of a dry mouth and increased risk of dental disease. Measures that can be used to reduce this risk are hydration, getting the patient to suck lemon lollies starting 24 hours after the treatment, and amifostine. And at our institution, we use all three measures, but the guidelines don't recommend for or against any of these measures. Work out of Korea showed that you should wait 24 hours before getting the patient to suck lemon lollies, because if you start before, then all that does is increase blood flow to the salivary glands and increase the delivery of the radioactive iodine to the salivary glands. So they should wait 24 hours and then wash out whatever radioactive iodine is there with sucking lemon lollies. And the use of amifostine, there's work that came out of Germany, and that's why we use the drug as well, because of that evidence. Now, radioactive iodine can cause a transient alteration in taste. I've had more than one patient tell me the beer didn't taste as good after the radioactive iodine, but don't worry, they were able to drink beer later on because their taste did come back. Fertility, women can get temporary amenorrhea for 4 to 10 months, but long-term fertility is not affected when low to moderate doses are given. But there is some evidence that menopause may occur about 1 year earlier. Radioactive iodine may cause a temporary reduction in sperm count, but infertility, miscarriage, and fetal malformation is not elevated in the long term in those receiving low to moderate doses. There is a very low risk of secondary malignancies, including leukemia, stomach, colorectal, kidney, bladder, and salivary glands. And thus, you always need to do a risk-benefit analysis before giving radioactive iodine. And that's why I don't give radioactive iodine in low-risk disease unless I really have to, because of the presence of antibodies. Another potential complication is nasolacrimal gland dysfunction due to blocked tear ducts, and this can be corrected surgically. Now, no nuclear medicine talk is going to happen without showing you some scans. So I just want to show you some recent patients that we've had in the last year or so. This is Philip. He's a 67-year-old man who underwent a total thyroidectomy for papillary carcinoma of the thyroid with vascular invasion and lymph node involvement. So he was determined to have intermediate risk disease, and we gave him in the order of 100 millicuries. And here is his post-treatment scan. And this is a pretty typical post-treatment scan. So he's got uptake here in the thyroid bed. This spot here is high in the thyroglossal tract. But as you can see on the scan, there's a lot of treatment sitting in his colon, and the colon doesn't need to be treated with radioactive iodine. This is not an uncommon appearance. In our country, we have to admit any patient who receives over 15 millicuries. They have to be isolated in hospital until their levels drop. So they classically come in on a Friday, out on a Monday, they stay in over the weekend. And because they're sitting in that room for 3 days, they're often constipated. So often they come down to the nuclear medicine department on the Monday and they've got all this activity sitting in bowel. And so we have to give them an aperient to clear that because the bowel doesn't need to be treated. Okay, I'd like to present the story of Marina. Marina's only 1 day difference in age to my own daughter, so I take her very close to my heart. Also, her mum doesn't live in our country. Marina was born overseas, and in her country of origin, when she was 16 years of age, she was found to have a thyroid nodule, and the biopsy was benign. She represented on migration here to Australia at the age of 23 and was found to have papillary carcinoma of the thyroid with extensive lymph node and pulmonary metastases. She underwent a total thyroidectomy, central and left lateral neck dissection, and we gave her post-operative 150 millicurie dose in 2014. And at the time of the treatment, her TSH-stimulated thyroglobulin was 15.3. In the following year, we gave her a similar dose. And you may wonder, I order 150, but 1 year I get 156, another year I get 148. Because it's radioactive, it's not like a drug where you know exactly to the microgram how much you're giving. We have to accept plus or minus 10% of the prescribed dose. So she was given another approximately 150 millicurie dose, and her TSH-stimulated thyroglobulin was similar at 16. Now, before she was operated on and before she received any radioactive iodine, she did have a chest CT, and I didn't perform a follow-up chest CT until after her second treatment dose, and the radiologist reported that there were still multiple sub-centimetre lung nodules with no change in CT appearances compared to the pre-treatment scans. So I'll just show you her radioactive iodine scans. So she had a lot of, even after having extensive surgery, she still had a lot of disease in the neck, and the treatment went there. And you can see she had these multiple iodine-avid pulmonary metastases. This was her scan after the second treatment dose the following year. And you can see uptake in the neck has largely resolved, possibly a small little node here, and really minimal uptake in the lung metastases. So we didn't think any further radioactive iodine was warranted on the basis of this scan. So she's now 30 and clinically very well. She's been monitored every 6 months with clinical examination, serial neck ultrasound, which has never demonstrated any abnormality, and her thyroglobulin has been quite stable since 2015, measuring 2. I haven't done any more chest CTs because I didn't think they were going to alter my management. And she's a young girl, and the breast dose from a chest CT is not insignificant. And again, you have to do a risk-benefit analysis. At the present time, I don't see the benefit of doing a chest CT because her thyroglobulin has remained quite stable. But if others think differently, I'm happy to do one. So I'd appreciate your opinion. This is another girl who migrated to our country. So she's 41 now. But when she was 31, she was operated, and I unfortunately don't have any of the pathology. She underwent a total thyroidectomy for papillary carcinoma of the thyroid. And 6 years later, in 2017, she underwent a left lateral neck dissection. Now, she's a very intelligent girl and she knows exactly what's happened to her. And she said she had received 4 doses of radioactive iodine in her country of origin. The initial dose was 180 millicuries, and then she got 3 lots of 150 millicuries. And she informs me that her post-radioactive iodine scans on the last 3 occasions were entirely normal. So she was referred to us because she had a rising thyroglobulin, and would I give her more radioactive iodine? As you can imagine, I was not keen at all to give her any more radioactive iodine. So we did some scanning. Now with her TSH stimulated investigations were with thyroid hormone withdrawal. She was used to doing this. And she also was quite strict with her low iodine diet because she had been through the process before. So I'll just show you her scans. This is her I123 whole body scan, and you can see there's nothing abnormal there at all. Normal uptake in the salivary glands, oral mucosa, nothing. This is normal uptake in stomach and bowel, and nothing abnormal in the neck or chest. We did an TSH stimulated FDG PET. And you can see there is this tiny FDG, oh no, this is on the iodine, sorry, nothing in the right neck on the iodine SPECT study, especially here, nothing, no iodine uptake there. But we did do an FDG PET study, and we found an FDG avid node sitting behind the right jugular vein. So she's already undergone left lateral neck dissection. She's probably got more than this node involved in the right neck, and this is probably the source of her elevated thyroglobulin, and I think ultimately she'll probably require a right lateral neck dissection, but I wasn't going to give her more radioactive iodine. Now this is Otto. So Otto's 81 now, and in 2017, he presented with a cerebral metastasis from papillary carcinoma of the thyroid, which was resected. The cerebral metastasis was resected. He proceeded to total thyroidectomy, central and left lateral neck dissection. He had quite bulky left lateral neck disease. He was given an approximately 150 millicurie dose, and on his post-treatment scan, there was uptake in the thyroid bed, but at sites of known pulmonary metastases, there was no radioactive iodine uptake. He was commenced on 3 months of BRAF inhibitor therapy, vemurafenib and cobimetinib, and we then performed an iodine 123 scan after 3 months of BRAF inhibitor therapy, and this resulted in redifferentiation with uptake in right cervical lymph nodes and pulmonary metastases. And as a result of that, we gave him a second treatment dose, and his post-treatment scan did show good uptake, and he had quite a subsequent thyroglobulin fall and stabilization of his pulmonary metastases, and he did well for a number of years. He's had more problems lately, but I'll just show you his scans. So here is his post-operative scan, and there is some uptake in the neck, but at sites of known pulmonary metastases, there's no iodine uptake. After 3 months of BRAF inhibitor therapy, this is his post-treatment scan, and you can see there's a lot of uptake in nodes in the neck and in his pulmonary metastases. So here you can see a metastasis which is now taking up iodine, another metastasis here taking up iodine. So this is an example of redifferentiation therapy. And the last case I want to show you is Dora. So Dora is, she's over 80 now, and in November 2014, so six and a half years ago, she underwent a total thyroidectomy, central and left lateral neck dissection for a poorly differentiated thyroid carcinoma with lymphovascular invasion and extensive lymph node involvement. We gave her a big dose post-operatively, and on her post-treatment scan, she had evidence of bone metastases in T3, T12, and the right seventh rib. Despite good uptake in these bones, she developed pain in the T3 metastasis, and she was referred for external beam radiotherapy, and this resulted in good pain relief. A year later, we gave her a big dose, and her TSH stimulated thyroglobulin was even higher at 892. Again, the post-therapy scan showed good uptake in bone lesions. We did an FDG PET scan later on that year, and there was actually very low FDG uptake at sites of known disease, significantly less than the radioactive iodine uptake. And this suggests that even though she's got metastases, it's not very aggressive disease. In November 2018, so more than 2.5 years after her last dose, her thyroglobulin continued to rise. We gave her a big dose, and the post-treatment scan again showed good uptake in the skeletal lesions, but despite this, her thyroglobulin continued to rise. So she was considered to have radioactive iodine refractory disease, and she was referred for consideration of TKI therapy, but she was actually quite well clinically, and there are side effects from TKI therapy. We have been able to manage her painful lesions with external beam radiotherapy, and I spoke to her son last week, and he said she was actually very well, had no pain, and you wouldn't know there was anything the matter with her. So that's just a range of patients, and here are her scans. These are Dora's scans. So this hot uptake here, that's actually her T3 metastasis. And here's her other metastasis in T12. And here's her seventh rib metastasis. You can see we've done SPECT CT, so it's very avid uptake in this T3. Uptake here in T12, again, quite avid. Uptake in her seventh rib. This was a PET scan done a couple of years after that iodine scan I just showed you, but really she didn't have very avid disease where there was known disease, and she actually has a small liver metastasis here, but she's overall hasn't got very aggressive disease on FDG PET. So that's the end of my talk, and this is my sunset slide. So thanks, I'm happy to try and answer any questions.
Great. Monica, thank you very much. And I would again encourage all of our listeners to give us their feedback on any questions that they have for Dr. Rossleigh here. Monica, I have a number of questions for you. You spoke at the very outset about the volume of disease and what is considered amenable for use of radioactive iodine. Can you be a little bit more specific in the situation related to the presence of either residual or recurrent lymph nodes? What volume do you see as being the cutoff, if there is one, for treating with effectively treating with radioactive iodine? How do you size that up here?
Well, I don't think radioactive iodine's good for lymph node disease. For some reason, it doesn't necessarily get into the lymph nodes. So in general, I think cervical lymph nodes need to be cut out. And the beta rays travel only a very short distance in space. So I can't give you an exact dimension, but I think if they're palpable nodes, then we're not going to be able to treat them.
Okay. If I could just pick your brain a little bit on, there has been interest in the use of remnant ablation in specific subsets of patients who have not been deemed to be candidates to undergo completion thyroidectomy. One such patient might be a patient who suffered a vocal cord paralysis at the time of the initial surgery and is quite reluctant to undergo a completion thyroidectomy. And even after waiting for a number of months, there's no signs of resolution. Is that a patient that you would consider ablating that remaining lobe in order to use radioactive iodine to look both from a diagnostic as well as from a therapeutic for the rest of the body? How do you feel about that?
Well, I've never done it. I've never had to do it. But if you remember in the old days when we used to do thyroid scanning for evaluation of thyroid nodules, a thyroid cancer would not take up the iodine. It was the normal tissue that would take up the iodine. So normal tissue takes up radioactive iodine in preference to cancer cells. I've never had to give radioactive iodine to try and ablate a whole thyroid lobe, and I actually don't know how successful that would be. I'd be interested in your experience in it because I haven't had any experience with that.
Yeah, so I have never done it. There were reports out of Boston of doing that, and just didn't know if you had any particular thoughts related to that. And I can imagine patients who may not be deemed candidates for medical reasons to undergo a follow-up surgery in a near term, that one might be interested in considering alternative options. But I'll move on from that. If you don't have any experience in that area, I certainly don't, but actually just encountered a patient with a vocal cord paralysis that was referred to me from her initial surgery, and she was questioning the potential role of radioactive iodine to avoid a second operation here. So
we've never done that, so I can't really speak to it.
okay,
Yeah.
alrighty.
Yeah.
Now, what is your advice for women who undergo remnant ablation in terms of when they can consider conceiving? Can you give us some parameters related to that?
We always recommend that they wait at least 6 months. That's our standard recommendation after radioactive iodine treatment. Look, and that's a fairly conservative recommendation because radioactive iodine, it's got a half-life of 8 days, and that's if it's just sitting on the shelf or on the bench. There's also biological excretion, and we want 8 half-lives to have gone before it's out of the body. In case any egg has been exposed. So that's 64 days, and then we double it. So actually 6 months is quite a conservative recommendation. Some women have fallen pregnant before then that we've had to deal with, and depending how close it is to the conception, we haven't had any problems earlier than that, but our recommendation is to wait 6 months. I mean, the danger is that the child's going to have the thyroid gland wiped out by the radioactive iodine, and they'll need thyroid hormone. And then there's also the theoretical risk of, radiation exposure and cancer induction. But our recommendation, even for remnant ablation, is to wait 6 months because it's the same as in a thyrotoxic patient. when we give radioactive iodine, we tell them to delay pregnancy for 6 months.
Great. And I assume that's given the half-life that you just quoted, that's regardless of the initial dose.
Correct, because remnant ablation, 30 millicuries, that's twice as much as we give for Graves' disease. We give 15 millicuries, and we still tell those ladies to wait 6 months.
Okay. The idea that the concern about radioactive iodine-induced breast cancer, which you alluded to, has been written about. It seems like you have pretty clearly dismissed that. Was that a fair assessment?
Okay, so I think if you're going to get a radiation-induced cancer, it won't occur in under 10 years. So I think 2 years from her radioactive iodine treatment is too close to say it's a radiation-induced cancer. But all I can say, I'm very glad that I did decide to not give her the treatment when there was breast uptake, and her post-treatment scan a month later showed no uptake in the breast. But in general, you know, when you give external beam radiotherapy as well, cancer induction, it usually occurs at least 10 years after the radiation. So I think 2 years was too close in her case.
Got it. Have you seen any cases of either salivary gland or breast cancer that given the 10-year window that you've experienced in your career, that you think may have been attributable?
Yes, I've got a patient who I probably treated, I think it was like 15 or 20 years ago, and she presented about 18 months ago with a salivary gland tumor. She needed 2 doses of radioactive iodine to ablate her disease, so I'm pretty sure that was a radiation-induced malignancy. But as far as breast cancer, I think there is a higher incidence of breast cancer amongst women who have thyroid cancer. So I can't tell you whether it's from the radioactive iodine or not. I think it's an epidemiological fact. They seem to be more prone to it. And breast cancer is very common. I mean, in Australia, I don't know what the figures in the States are, but in Australia, it's 1 in 8 women get breast cancer. So it's a very common tumor.
Yes, I think those numbers are, if I remember correctly, are quite similar in the U.S. I've seen anywhere from 1 in 8 to 1 in 10. If I could just pick your brain a little bit about withdrawal versus thyrogen, and when there are absolute indications where you will advise withdrawal prior to administering therapy.
Well, I think it's preferable in patients with known metastatic disease. So, you know, like Otto with his pulmonary metastases, you know, with bone metastases, I think that's preferable. But when I started giving radioactive iodine, we didn't have thyrogen available, and we really used to make patients very sick we'd make them hypothyroid. You know, they'd have the operation, shock of the diagnosis, make them hypothyroid, give them radiation, and then they'd come and see you 6 weeks later and say, I still feel lousy. Whereas with the thyrogen, you know, they handle the treatment a lot better because we haven't made them hypothyroid. But I think in the presence of metastatic disease, that would be the main indication to insist on withdrawal.
Okay. And as it relates to metastatic disease, how well does RAI cross the blood-brain barrier? And what is for folks with CNS metastases, and do you consider that an effective modality?
I don't think so. The only patients I've had with I haven't had patients with multiple cerebral metastases. They've had solitary metastases, and they've been surgically excised. I've been fortunate to not have to consider treating someone with multiple cerebral metastases, but I don't think it crosses sufficiently well enough to treat the metastases in the brain.
Great. Okay. And what about, if you could just come back to the issue of dosimetry? I know that it's not widely used, but maybe if you could just tell us perhaps the profile of a patient that clinicians who are should be thinking about that and referral to a center that does dosimetry. If you could give us a little bit more background on that and how we should be thinking about that.
Well, I think it would be particularly useful in an older patient because older patients may be very sensitive to radioactive iodine. And so you may have to significantly tailor down their dose, or a young person with aggressive disease who could probably tolerate a higher dose. And the other area I would think is in the presence of renal impairment, where you can really knock off their bone marrow by giving them too high a dose. So I think that'd be the three main areas, but because I don't do it, I haven't got the facility to refer for it. I haven't had any recent experience with dosimetry, unfortunately.
Okay, all righty, fair enough. Maybe I'd like to just talk for a little bit about patients with recurrent disease and what your approach is to that particular patient. Do you, and I assume it's perhaps somewhat different based on the timing of recurrence relative to their either initial or their last treatment, but someone who presents with either recurrent local or regional disease, do you think that there is a role for doing upfront imaging, whether it be a combination of RAI with PET or RAI alone, in order to get a better handle on what the iodine avidity is for that recurrence before it's resected?
Yeah. I think it depends where the recurrence is. Like if it's a patient with papillary cancer who's got recurrence in the neck in regional lymph nodes, we generally don't tend to do much pre-operative imaging. But if it's someone with more, you're concerned may have more disseminated disease, then you could consider doing radioactive iodine or FDG PET imaging. But I know in patients with papillary, when it comes back in the lateral neck nodes, for example, generally the surgeons do CT scanning and neck ultrasound CT scanning, and we tend to not image them if it's just local disease in the neck. But if there's concern of possible more systemic disease, then we would do FDG PET and possibly radioactive iodine imaging.
So I think that what I'm trying to get a better handle on is trying to determine what the role is for adjuvant radioactive iodine after removal of recurrent or even or residual disease, and whether or not there's value added in doing so. And so we often struggle with whether or not we should be doing imaging before the disease is resected in order to assess the avidity of that disease. And therefore perhaps assessing the role of radioactive iodine after surgery. Do you have any thoughts about that particular scenario, which comes up fairly frequently?
Yeah, not in my practice, but I mean, I can see the sense of that. You want to know if it's iodine avid. Yeah, I can't tell you I've got a vast experience in that kind of scenario. We'll do iodine and FDG PET if we're concerned about disseminated disease, but if they're going to go for a lateral neck dissection, we look at the histology. If there's extranodal extension, then we would consider giving radioactive iodine. I have to admit we don't do much pre-operative iodine before they cut out the nodes.
Okay. So perhaps you can give me some insight here. In a patient who has either recurrent or assumed persistent disease that emerges at a time period after their initial treatment, if somebody has undergone the scenario where they've had surgery and radioactive iodine after that followed, and then have new disease that emerges, your thoughts about the role of further radioactive iodine in that setting after surgical removal of that nodal disease? Is timing an issue, or what goes into your thought process in retreating those patients with recurrent disease?
Well, we look at the histology, as I said, and if we're concerned sufficiently to give more radioactive iodine, we'll do it. We want to make sure that it's not in proximity to any iodine contrast administered at the time of a CT scanning required for the surgical planning. And we usually wait at least 4 to 6 weeks after the operation before giving more radioactive iodine.
Okay, so in your mind, does it matter if nodal disease emerges within 6 months after the initial dose, or whether it emerges years later, in terms of what you perceive to be the efficacy of further dosing with radioactive iodine? How can we get a handle on that?
Good question. I don't know the answer. As I said, I think lymph node disease, radioactive iodine often doesn't go to the lymph nodes, and you have to cut those lymph nodes out. We would look at the histology after you've done the resection, and then determine, if we're worried sufficiently to give a further dose of radioactive iodine, just to prevent any seeding of cells that came out at the time of the operation. But I don't know about the time course, whether that would make a difference to us as to whether we would offer more radioactive iodine or not, whether it was in close proximity or, if we treated and then they had a recurrence a year later, then we would see what the histology showed and decide whether we're going to give more radioactive iodine. And whether it's a year or 5 years later, I think we would do the same process.
Okay, so there's no way to infer about the efficacy of radioactive iodine based on how quickly disease emerges after the last dose that they were exposed to.
Well, it depends where. I mean, if they end up with bone metastases after you've given radioactive iodine, then you'd think, well, the radioactive iodine hasn't worked. But if it's recurrence in lymph nodes, that's kind of a sanctuary area for the cancer cells, and we may not be able to reach those lymph nodes.
Okay, all right, terrific. I am absolutely indebted to you for this session. This has been absolutely invaluable. And so, given that we are pushing the 9 o'clock hour here, I want to thank you for providing this really outstanding lecture. And we have just put up, we just did put up our upcoming sessions. There we go. And invite everybody to join us in the coming weeks for these outstanding presentations that soon will come. So I wish everybody a happy weekend coming up here, and thank you all for joining us. Dr. Rossleigh, thank you once again.
Thanks a lot. Bye, everyone.
Bye-bye.
Bye.